You're listening to Med School Radio.
And here we are again in Tokyo. This is Simon, and we are listening to some smooth songs, jazz this time. And we are joined by our neighbors upstairs who are making some nice accompanying loud noises, baby cries at the appropriate moments, helping you remember these important points for the respiratory system final. So what I'm doing is I'm at Firecracker and I'm just reading the questions that are generated for me. So let's continue on. What are the four most common sites to which metastatic lung cancer spreads? When primary lung cancer becomes metastatic, it is most commonly spreading to the brain, adrenal glands, the liver, and the bone. Okay, so I want to read a little bit more about that because this is very important. Lung cancer can be either primary, originating in the lung, or metastatic, originating in another organ. A metastatic cancer in the lung is most likely to be present with multiple lung nodules. And there are several noteworthy complications of primary lung cancers. A Pancoast tumor is any tumor in the apex of the lung. One complication of Pancoast tumors is compression of the cervical sympathetic plexus on the affected side, which eliminates sympathetic innervation to the ipsilateral side of the face. This is known as Horner syndrome and manifests as the unilateral triad of ptosis, which is ipsilateral drooping of the eyelid, miosis, which is an ipsilateral pinpoint pupil, and anhidrosis, which is referring to a lack of sweating on the ipsilateral side of the face. And remember that lung cancer can also cause superior vena cava syndrome, which is a medical emergency. This occurs when local tumor growth compresses the superior vena cava. Obstruction of blood returning to the heart results, causing congestion in the head, neck, and upper extremities. So we said this before, but superior vena cava syndrome can present with syncope, increased jugular venous pressure, or blue discoloration of the face, arms, and neck. Now think about what two chronic home interventions for patients with COPD have been shown to increase mortality. Decrease mortality. Okay. Interventions shown to decrease mortality in patients with COPD are smoking cessation and supplemental oxygen at least 15 to 18 hours a day in order to titrate SaO2 to 90, from 90 to 92%. Next question. What are the four most common viral causes of atypical pneumonia? The most common viral causes of interstitial atypical pneumonia include adenovirus, CMV, influenza, and RSV. What are the characteristic findings on chest X-ray in chronic obstructive pulmonary disease? Chest X-ray shows characteristic hyperlucent lung fields. Air trapping can lead to flattening of the diaphragm. In severe disease, the heart can also become elongated and tubular-shaped as a result of the increased air in the thorax. What is the typical clinical course of bronchopulmonary dysplasia? Infants with bronchopulmonary dysplasia typically show improvement between 2 to 4 months. What are the treatment goals in COPD? The treatment goals are to reduce obstruction by dilating the airways and reducing mucus secretion and prevention of disease progression. What is a pleural effusion? Pleural effusion is an accumulation of fluid in the pleural space. So depending on the etiology, pleural effusions can be exudative, which is mostly protein, or transudative, or mostly water, or chylous. What are two distinct pathological processes included in COPD? It is a broader clinical classification of two distinct pathological processes, emphysema and chronic bronchitis. So this comes up a lot. COPD is a disease of chronic obstruction of airflow that interferes with normal breathing and is not fully reversible. So to say it again, it is a broader clinical classification of two distinct pathological processes, emphysema and chronic bronchitis. Sarcoidosis patients often present with which four symptoms of hypercalcemia? Bone pain, kidney stones, abdominal pain, or anxiety. So the mnemonic here is bones, stones, groans, and psychiatric overtones. That's hypercalcemia. What is the role of beta agonists in treatment of chronic obstructive pulmonary disease? Inhaled beta agonists act as bronchodilators and provide symptomatic relief. Long-acting beta agonists, such as salmeterol, are often used. What lipid level is typically elevated in a chylous effusion? Chylous effusions typically contain a triglyceride level of greater than 110 milligrams per deciliter. Okay, what is COPD? It's a disease of chronic obstruction of airflow that interferes with normal breathing and is not reversible. Patients with sarcoidosis have an elevated ratio of which cells in fluid from bronchoalveolar lavage? They have an elevated CD4 to CD8 ratio in fluid from the bronchoalveolar lavage. What breath sounds are often appreciated in COPD patients? Breath sounds heard on auscultation include wheezes, usually end expiratory, from obstruction, or crackles, which are usually inspiratory, from opening of collapsed alveoli. So remember that the crackles are usually inspiratory, and the wheezes are expiratory. Important stuff here, guys. Don't forget it. What type of cells comprise the bronchoalveolar subtype of pulmonary adenocarcinoma? The bronchoalveolar subtype of adenocarcinoma is comprised of columnar cells that often contain mucus. What is the cause of polycythemia in chronic obstructive pulmonary disease? Polycythemia may occur in response to chronic hypoxemia as a compensatory response in order to increase oxygen carrying capacity in the blood. Makes sense? Activating mutations in which three genes are commonly seen in lung adenocarcinoma? Patients with lung adenocarcinoma often have activating mutations in genes that include KRAS in smokers, EGFR in individuals of Asian descent, and ALK or anaplastic lymphoma kinase in non-smokers and younger patients. What is the effect of smoking cessation on the course of COPD? Okay, it's critical. It does not reverse the disease, but the rate of respiratory function decline reverts to that of a non-smoker. Avoid other pulmonary irritants that will increase mucus production. What complication of bronchopulmonary dysplasia carries a high risk of mortality? An important complication of bronchopulmonary dysplasia is pulmonary hypertension, which carries a high risk of mortality. What is the number one risk factor for COPD? Smoking. When is a 10 millimeter induration considered a positive PPD test? 10 millimeters PPD is positive at 10 millimeters if the patient has a condition that increases the risk of reactivation, including silicosis, chronic renal failure requiring dialysis, diabetes mellitus, injection drug users, healthcare workers, including medical students, and incarcerated individuals. So remember, that's 10 millimeters for people. So if you have PPD is positive at 10 millimeters, if the patient has a condition that increases the risk of reactivation, including what I just said. What are the three most common pathogens in Lobar pneumonia? The three most common causes of lobar pneumonia are S. pneumoniae, which is the most common, Legionella, or Klebsiella. What are the three most common bacterial causes of interstitial or atypical pneumonia? The most common bacterial causes of interstitial atypical pneumonia include Mycoplasma pneumoniae, especially military recruits or college students, Legionella, especially in smokers, and chlamydophilia. What pulmonary function abnormalities result from bronchopulmonary dysplasia? Decreased tidal volume, increased airway resistance, and increased ventilation or perfusion mismatch. What surface protein allows RSV to attach to bronchiolar and alveoli epithelium? Okay, we're talking about Paramyxoviridae, or RSV virus. RSV attaches to bronchiolar and alveoli epithelium via protein G, leading to necrosis and inflammation of bronchioles and alveoli. So remember, it's protein G with RSV. Okay. Explain the pathophysiology of the non-productive cough seen in atypical pneumonia. The pathophysiology of the non-productive cough in atypical pneumonia: there is an interstitial inflammation and an absence of exudative inflammation in the alveoli, which leads to a non-productive cough. What heart condition can be seen in patients with sarcoidosis? Cardiac involvement of sarcoidosis can result in restrictive cardiomyopathy. Okay, here's a question, a multiple choice question. A 36-year-old African American female is diagnosed with non-caseating granulomas and elevated gamma globulinemia and ACE serum levels. Which of the following is not associated with her presumptive diagnosis? Remember, this is a 36-year-old African American female. This should be a tip-off. So the choices are erythema nodosum, B, hypernatremia, C, epithelial granulomas, D, Bell's palsy, or E, hypercalcemia. And the answer is hypernatremia. Okay, here's the explanation. Given the patient's non-caseating granulomas, elevated gamma globulinemia, ACE levels, and African American origin, its likely diagnosis is sarcoidosis. Associated medical problems include restrictive lung disease, bilateral hilar adenopathy, erythema nodosum, Bell's palsy, epithelial granulomas containing microscopic Schoeman and asteroid bodies, and parotitis. I can't even say it. Uveo-parotitis. Remember that. That'll be easy to remember. Hypercalcemia. Macrophages inside the granulomas convert vitamin D to its active form, resulting in elevated levels of the hormone 1,25-dihydroxyvitamin D and symptoms of hypervitaminosis D that may include fatigue, lack of strength or energy, irritability, metallic taste, and temporary memory loss or cognitive problems. Remember that hypernatremia is not associated with sarcoidosis. Okay, 7 more to go here. Hang in there. A chest X-ray shows multiple well-circumscribed nodules in a patient's lungs suggestive of cancer. Is this patient's cancer more likely a primary lung cancer or a lung cancer of metastatic origin? Okay, these well-circumscribed nodules are, so what are they? The presence of multiple pulmonary lesions is more indicative of metastasis to the lung, more than a primary lung cancer. So here's a question again. I've asked this before. What is the most common metastatic tumors? Where are they found? In order of the most common metastatic tumors found in the lung, what are the orders? First is breast, colon, prostate, and bladder. I'll read that again. Lung metastases are more common than primary lung cancers. In order of the most common metastatic tumors found in the lung are as follows. Doesn't make sense, but I'll read it anyway. 1. Breast. 2. Colon. 3. Prostate. 4. Bladder. The presence of multiple pulmonary lesions are more indicative of metastasis to the lung than of primary lung cancer. What is the pathophysiology of Krabbe disease? The disease causes accumulation of ceramide galactose within lysosomes of brain white matter. The clinical features of Krabbe disease include progressive central nervous system degeneration within the first 6 months of life, optic atrophy and spasticity, globoid cells in areas of demyelination, and characteristic irritability. Patients with Krabbe are crabby. The disease can be treated with hematopoietic stem cell transplants in infants prior to the onset of neurologic symptoms. Remember, this is an autosomal recessive lysosomal storage disease. The problem here is with a deficiency of galactosylceramide beta-galactosidase, also known as galactocerebrosidase. What enzyme is deficient in Krabbe disease? Krabbe disease is an autosomal recessive lysosomal storage disease caused by deficiency of galactocerebrosidase. Yes, we are talking about a different system here. I don't know why I have these included here, but we'll just go on anyway. What is the treatment for Fabry disease? The disease can be treated with enzyme replacement, which must be continued for life. What are the clinical features of Farber disease? Farber. Let me just check on that 1 second. You see, I'm totally clueless. I didn't even recognize it. The clinical features of Farber disease include normal presentation at birth, clinical onset around 4 months of age, nodules on joints, vocal cords, which causes hoarseness, and severe mental and motor retardation. So we're looking here at the lipidoses. I'm going to just unmark these here because I'm not doing these right now. What are the clinical features associated with Niemann-Pick disease? The clinical features of the disease include red macula with a clear cornea and hepatosplenomegaly. Okay, that was it. We did 68 questions. Some of them were unrelated, but thanks for joining me on this review. We may do some more later. I might even look at osmosis later as we review for the respiratory system. Perhaps I'll look at some multiple choice questions, but thanks for tuning in, and we will see you next time.
You're listening to Med School Radio, coming to you from Central Tokyo.